My name is Rob Ramasco, and I have been drafted in the last 4.5 seconds to moderate the session, and we'll get right to it. The title of this session is Small, Few, and Different, Inequality in Europe's Health. One of the things I learned when I was a student of statistics, beware of averages. There's no such thing as average. And one of the things that's really important is to understand the very different groups and the impacts of public health and how they are impacted in different communities. And this is something that is important to each of us and we'll learn a lot more about today. So there is a lot of, you've seen the stuff, and we'll get right to it. I'd like to introduce our panelists. I will not read the biographies, we're running a little bit late. Suffice it to say, each one of them is accomplished, dedicated, and passionate about their work, and I'm sure you'll see it in their discussions. First is Gauden Galea, and Director of Division of Non-Communicable Diseases and Health Promotion of the Regional Office for Europe and the World Health Organization. So, Gauden, you're up.
Thank you, Rob, and thank you to the organizers for the honor of speaking at this session at the end of such a wonderful conference. I have to apologize for them because one thing I am going to do is to hijack my theme. Something happened last night that actually makes it very important that I talk to a new subject than the one you actually see. So I'm using the title more as a Trojan horse for the real subject that I want to talk about, but I'll take you there in a moment. This is a graph, a scatter plot of standardized mortality for non-communicable diseases by Human Development Index. I suspect everyone here is familiar with a composite index, the Human Development Index, that incorporates everything from education to GDP and a variety of measures of health, economic, and social well-being. And one of the immediate things one sees as one goes up the HDI scale is that standardized mortality from non-communicable diseases goes down. This was so obvious to anyone who sees the scatter plot, but at the same time, it is one of the major barriers that existed when we were trying to get the UN high-level meeting and the political declaration on non-communicable diseases eventually adopted. Many people kept saying that non-communicable diseases were a problem of the rich and that they were not a problem of the poor. And as you can see, by almost any measure of economic or health well-being, the lower end of the scale has a much higher level of mortality from non-communicable diseases. You actually get less NCD as you grow richer. I use this as an entry point for something that I have never done before on stage, and I am just hoping actually works. You've all seen Hans Rosling's presentations on life expectancy and GDP and infant mortality and how they vary over time. I've tried to do the same to give you a link of what are the major forces that buffet the epidemic of non-communicable diseases, but taking the example of Europe. I'm hoping that you can see that on the vertical scale are diseases of the circulatory system, standardized on a linear scale. On the horizontal scale, we have gross domestic product per capita on a log scale in order to exaggerate a bit the horizontal movements. And the thing is animated, so if I were to choose, say, one country that is famous in the field of non-communicable diseases, Finland, and we took from 1970 onwards to 2008, you can see Finland move in a trajectory that is familiar to everyone. It declines over time, and if you see what's happening here in the 90s, you can see that actually Finland was able to retain its downward migration in the circulatory disease mortality scale, even though it was undergoing a fairly major recession in the early 90s. So if we take Finland as our anchor and we compare other countries in Europe, we can see that there is a huge inequality in the experience, but some general patterns. If, for example, I take Slovenia and Hungary, and we take the axis back in time, you can also see general patterns, what I would call the Western European pattern of reduction of mortality with Hungary and Slovenia in the latter years coming down. Very similar in pattern to Finland, but somehow moved to the left, meaning they were poorer, or higher up, meaning their experience is worse than Finland's. But generally, this pattern we have been seeing in the west of Europe, with countries improving in their economy and at the same time improving in their experience of circulatory and overall NCD mortality. In order to conclude this initial part, I will just show you two other countries further east in Europe and compare Moldova to its large neighbor, the Ukraine, to the 1990, with the breakup of the Soviet Union and the independence. I will zoom in, if the technicians will help me there. Zoom in to the area where the story takes place. And there's a very interesting, for those of you, of course, who are familiar with the geography, Moldova, the small country to the west of and adjacent to the Ukraine, both of them have a very interesting experience after independence. Immediately their story is one of recession and increasing mortality in a tango that mirrors each other in a very politically, economically, and historically interwoven sense. In 1994, the economy stabilizes, and to some extent, there is a decline in mortality until 1998, 1999. The economy starts to improve, but something happens, possibly the distribution of the prosperity, of the increased production in the country does not get distributed equally across, or some other story of acclimatization, but the two start to rise again in mortality, and now the Moldova starts to come closer to the West and depart from the influence of the Ukraine. And you can see that from 2005 onwards, Moldova starts to take on the pattern of very much close to what we saw earlier in Finland and in Hungary and Slovenia, a more Western European, while the Ukraine is still floating fairly high up away from the European average. Moldova, after 20 years of political and social upheaval, comes back in mortality, in circulatory mortality, to the place where it was when the whole story started in 1990. I could tell many stories of this nature, and to me they are extremely impressive. They say to me a couple of things. One, that non-communicable diseases are not chronic. Whatever we may say, they're chronic on the individual stage. When I get diabetes, I get it for life, and I can control it. I can go into chronic care. I can do things to increase my functioning in society, but I have that chronically. But as a population, as a country, we can see major changes in mortality, even from year to year, influenced even by small changes in economic production or in the politics or in the history of a country. Within that, I connect all these changes that have been happening and all these differences in Europe. I won't take you into the details now that we've seen the pictures moving. It's much nicer than seeing them as a slide. But generally in Western Europe, we have seen a decline in circulatory mortality over the last 30 years. But even in the European Union, we can see many signs of inequality with, for example, the older members like the United Kingdom having its red line, its trend in circulatory mortality well below the gray European average, while other more recent entrants like Bulgaria, like Latvia, like Romania, hovering above the average. Even within the European Union, we can see differences between one group and another. If we go further west, the elevation above the European average is much higher. If we go to the Caucasus, to Central Asia, we can see that the levels of circulatory mortality have been very high. And if we then were able and had the time to connect them to what's happening in the economy, we would see very interesting stories such as the ones that I started off with. This is the same for cervical cancer. So why have I focused on this introduction? Partly because yesterday at 6:30 in the evening, a major new publication was released. And for those of you who have their pens out, you might want to take the web address and go and download it. For the first time, 119 countries on a global consultation, on behalf of the whole process, the whole global process leading from the UN high-level meeting, have agreed on a global monitoring framework for non-communicable diseases. They said these inequalities across countries, across GDP, across Human Development Index, and their influences on non-communicable diseases can be brought under control by a number of known cost-effective interventions that can result in a measurable and targeted improvement in the burden of non-communicable disease. They have agreed on 11 targets. For those of you who have been involved in the process, you'll see some minor changes. I don't have the time to go into them, but you will see that there are more targets than most people expected. If people had looked at the literature and the discussions in the journals, one would have expected one mortality target, 4 risk factor targets, and 1 health system target. In fact, the aspirations of the groups gathered in Geneva until 10:30 at night last Wednesday resulted in a much more ambitious group of targets, somewhat aspirational. And alongside them, they agreed on a series of indicators for premature mortality and cancer incidence, indicators on risk factors, 3 indicators on the harmful use of alcohol, fruit and vegetable intake, overweight, total cholesterol, salt, sodium intake, fat intake, etc., and a series of health system response indicators that range from cervical cancer screening and human papillomavirus vaccination through to palliative care and policies to reduce the marketing of foods to children. This group of indicators being the most surprising because they are, many of them, indicators of policy and processes that are, yes, in most instances, very well established in the evidence, but had not been up till this week part of the overall discussion, and it was expected that many of these indicators would end up in the global action plan. So we are at a stage in the process of implementing the UN high-level policy meeting political declaration. We're at the stage where on the 5th and through the 7th of November, a formal consultation has concluded on the global monitoring framework. And now we expect that in January, the Executive Board, and in May, the World Health Assembly will endorse them, and from there, they will go to the UN General Assembly. What is the link with this meeting, and why did I think it's so important to bring it to the attention of this group? Because of the next process. I won't go through all those little red boxes, but they basically say that the next stage in February or March of 2013, there should be an informal discussion on the development of a global action plan for non-communicable diseases. So yes, we have the monitoring framework. Yes, we have the awareness of the trends and the inequities and the patterns in countries around the world, but it is up to the public health community now to advise WHO through the member states over the next 3 months on what should be the actions that we take forward from here onwards. There are some challenges. We ourselves in Europe have tried to assess the capacity to measure the indicators, and we have found a number of things that concern us. For example, at least 1/4 of our countries are unable to report on the NCD risk factors, and only 4 countries of the 53 member states of Europe are able to disaggregate their data. So yes, we believe there are inequalities. We can see them between countries, but we have no reliable way of measuring them within countries, at least not in a way that is consistent and comparable over time. We also have concern that globally, only a small proportion of the world's community are covered by evidence-based public health interventions. This is an older slide, but it illustrates how few what a low proportion of the world's population is covered by the interventions on Framework Convention on Tobacco Control. Here in Europe, we have very uneven implementation of policies. For example, the price of a pack of cigarettes goes from $1 in Kazakhstan through to $10 in Ireland. The price of beer goes from €0.5 in the Czech Republic to 2.5 euros in Norway. There are sometimes orders of magnitude difference in the way that we implement policies that are evidence-based. In the field of nutrition, this slide illustrates a range of nutrition policies across the 27 EU member states. The solid bar to the right illustrates the number of member states that have implemented the policy. I won't go through it all, but just to say that there is very good implementation